Hi everyone, this is your podcast for Depressive Disorders. Major depression is one of the most common illnesses of any type, either medical or psychiatric. Depression is considered the common cold of mental illness. It affects people of all ages and backgrounds. It's currently the leading cause of disability in persons 15 to 44 years old, and by 2020 it's projected to be the second leading cause of disability for all age groups. As far as the incidence of depressive disorders, depression affects approximately 14.8 million people 18 years or older, or 6.7% of the population in any given year. They think that it affects probably 11.9% of adults 65 years and older, especially with rates for elders in hospitals and long-term care facilities thought to be even higher. In children, they think it's 1 to 2% of kids of ages prior to puberty and 3 to 8% of adolescents. 50% of all adults with depression will report that their depression began before age 20. It can develop at any age. There's an average onset of 32 years. There's another type of more of a chronic mild depression called dysthymia, and it affects approximately 1.5% of the U.S. population 18 years or older in a given year. Depressive disorders are more prevalent in women than in men. As a matter of fact, they state that females have a 70% higher probability of depression than men. Genetics, sociocultural factors, hormones, and other elements may account for this disparity. You might recognize some of these names on the slide. These are some famous people who have experienced major depressive disorder. Depression, like all psychiatric illnesses, is thought to originate from a combination of the interaction of genes, environment, individual life history, development, and neurobiologic makeup. There is a definite genetic influence. Family studies reveal that adopted identical twins show a 45 to 60% rate of both of them developing depression. They blame neurotransmitters a lot in this whole thing, when you're looking at neurobiologic makeup. And the neurotransmitters thought to be involved in depressive disorders are norepinephrine, serotonin, and dopamine. When norepinephrine is decreased or decreased along with decreased serotonin, or vice versa, it's thought to bring about depression. So more about that later, but just something for you to be thinking about when we get into talking about meds. Some risk factors for depressive disorder, and as I said, exact causes have not been discovered yet, but there are risk factors. And as we've already talked about, gender, higher in women than men, prior episode of depression, family history, stressful life events, current substance abuse or use, medical illness, and few social supports. Decades of family studies have found an increased risk for depression in clients with first-degree relatives who have had depression. As you can see from the slide, and this picture is in your book as well, there are several areas of the brain which seem to be especially affected in depression disorders. So, the thalamus, the cingulate gyrus, the amygdala, prefrontal cortex. So again, you can review the slide and have some ideas about that. Psychodynamic theories include, these postulate that clients with depression, as you can see from the slide, have unexpressed and unconscious anger about feeling helpless or dependent on others. They cannot express this anger toward the person or people on whom they feel dependent, so their anger turns inward. Anger begins in childhood when basic developmental needs are not met. Psychoanalytic theorists believe that there is a link between unmet needs in childhood and later mood disorders. They match feelings of helplessness, dependency needs, and anger with interventions that enhance functioning and self-perception. Learned helplessness. I don't know if you've ever heard that term before. Perhaps you have. Learned helplessness comes into play here in that people susceptible to mood disorders have come to believe that they are ineffective and have no influence on factors that cause their suffering. Behaviors include passivity, negative expectations, feelings of helplessness, hopelessness, and powerlessness. One would also note that these are also symptoms of major depression. Now, our cognitive theorists believe that depression is a manifestation of errors in thinking and unrealistic attitudes about the self and the world. Cognitive errors that precede mood changes involve thinking wrongly about the self, having a negative view about the ability to achieve goals, and being unable to experience pleasure. Self-depreciation and unrealistic expectations cause recurrent dissatisfaction, which leads to depression. According to the DSM-5, these are kind of the categories for depressive disorders: major depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, SAD or seasonal affective disorder, postpartum depression, depressive disorder due to another medical condition, and substance or medication-induced depressive disorder. Depressive illnesses are categorized according to symptoms, severity, and persistence. Depressive disorders are associated with disturbed psychological, physiologic, and social functioning, and there are wide-ranging groups of symptoms, including what you see on the slide: disturbances in daily patterns, sleep, appetite, weight, libido; disturbances in cognition, attention, memory, and thinking; disturbances in impulse control, risk for suicide, homicide; disturbances in behavior, withdrawal, lack of pleasure, fatigability; and physical symptoms such as headache, stomachache, and muscle tension. Symptoms of major depression, and I'll show you some more on the next slide, are depressed mood, something called anhedonia, A-N-H-E-D-O-N-I-A, which means that the person can no longer get pleasure in something or feel pleasure in maybe an activity that in the past they have felt it has given them pleasure. So anhedonia is maybe a new word for you. Recurrent thoughts of suicide or death, feelings of worthlessness and self-blame. Motor disturbances can be agitation or severe slowness. They have something called anergia, A-N-E-R-G-I-A. Anergia meaning, just no energy. They just have slow movements and slow speech and so on. Vegetative symptoms, and we'll talk more about those in a little bit. Substance abuse, social withdrawal. Patients may disregard grooming, cleanliness, personal appearance. They might have a stooped posture, dejected facial expression. They might appear disheveled, downcast, lack eye contact, and may be tearful. They may be agitated but will not exhibit bizarre or odd behaviors. They might wring their hands or kind of pick at their, clothing or something. Many resist attempts from others to engage them in the environment. They tend to exhibit withdrawn behavior within a very circumscribed area like their bedroom. For a diagnosis of a major depressive disorder, 5 of these symptoms must be present during a 2-week period. Symptoms must be present most of the day, nearly every day for 2 weeks, and cause significant distress or impair functioning, inability to work, decreased concentration, and so on. You can see them on the slide: depressed mood most of the day, significant weight loss, insomnia or hypersomnia, fatigue, feelings of worthlessness, diminished ability to concentrate, recurrent thoughts of death. No history usually of manic behavior here. We'll talk about bipolar disorder after, in a subsequent lecture. Cannot be attributed to substance use or a general medical condition. Depression is often described as the person feels sad, blue, unhappy, down in the dumps. We all may feel this way at times. True clinical depression is a mood disorder in which these feelings of sadness, loss, anger, or frustration interfere with everyday life for an extended period of time. Anhedonia is present. Activities once enjoyed no longer are. The average onset of major depressive disorder is in the mid-20s. It can occur at any age, in all ethnic, racial, and socioeconomic groups. About 3/4 of those who have a first episode of depression will have another sometime in their lives. Vegetative states have to do, or vegetative symptoms have to do with decrease in appetite. Constipation kind of goes along with that, with the vegetative symptoms. They're slow in their movements and so on. And so everything's kind of slowing down. We're going to watch a video in class that will really exhibit a major depressive disorder, and you will see the vegetative symptoms in a person on the video. Sleep disturbances. Oftentimes a person has early awakening insomnia. It leads to fatigue and exhaustion. Some have hypersomnia. They want to sleep all the time, and actually too much sleep is often as bad as too little sleep. Psychomotor retardation, again, decreased energy, thinking, and body movements. Slowed, speech is slowed. Also agitation, though. Cannot sit still, paces, wrings hands, picks at nails, skin, and clothing. So you will see a wide variety of symptoms depending on the patient. Can be a single episode or recurrent. The milder chronic form is called dysthymia, and it's a chronic disorder, periods of depressed mood interspersed with normal moods, fewer physiologic symptoms. Depressed, irritable mood most of the day, occurring more days than not for at least 2 years, 1 year for children and adolescents. Chronic depression here is less severe than major depressive disorder, but generally lasts longer. There are fewer physiologic symptoms like disturbed sleep, alteration in activity, and decreased weight. Essential symptoms include almost daily depressed mood for at least 2 years, but without the necessary criteria for major depressive disorder. If the person has 2 or more of the following: appetite change, sleep change, fatigue, decreased self-image, hopelessness, and decreased concentration, usually indicative of dysthymic. During 2 years, symptoms are never absent more than 2 months, can often continue to work and do activities even though the person appears to be very sad. Another type of depression is premenstrual dysphoric disorder. It's not PMS, as the stress level is different. Mood swings, irritable, anxious, depressed during premenstrual time, can include hallucinations and delusions. Anhedonia, impaired concentration, fatigue, change in appetite. These folks with premenstrual dysphoric disorder tend to be overweight, and they will have some of these physical signs and symptoms. Symptoms peak and subside. Extreme mood changes. Another one that you might be familiar with is SAD, or seasonal affective disorder. There is a relationship here between light, biologic rhythms, and mood. Occurs in relationship to seasons. Fall or winter depression is most common. Typically, this seasonal affective disorder, this depression, ends in the spring. There is no known cause, but it is believed that decreased light may affect the biological clock that regulates sleep, mood, and hormones. Neurotransmitters affected by light, and they work better with serotonin. In other words, you need light, like sunlight, helps increase your serotonin levels and so on. Same symptoms as depression with extreme fatigue. The person wants to sleep a lot. They have an increased appetite, weight gain, and treatment for seasonal affective disorder, antidepressants, phototherapy, outside time. Postpartum depression may last for a few weeks to several months. It is not to be confused with baby blues, which is common 3 to 5 days after birth, and does not, when it's baby blues, it does not interfere with the care of the baby. Postpartum depression usually begins with between the first 2 to 3 weeks up to the first year after birth and does interfere with the care of the baby. Postpartum psychosis is an extreme form of postpartum depression, and it's a severe psychiatric emergency. Symptoms can occur up to 2 weeks after delivery. Mother has hallucinations and delusions. The psychosis increases the risk of harm to baby or self. Symptoms are similar to rapid cyclic manic or mixed bipolar episodes. A person with the postpartum psychosis, dramatic mood swings, disorientation, disorganized or impulsive, erratic behaviors. They experience destructive delusions and command hallucinations to harm baby or self or both. So nurses work in many settings that care for clients with depressive disorders: acute care settings, step-down programs, day treatment programs, community-based programs, outpatient clinics. The programs in these settings utilize a multidisciplinary approach. Many nurse practitioners work in an outpatient setting, seeing clients with mood disorders for medication management and psychotherapy. The interdisciplinary approach to long-term management of depression includes the treatment modalities of meds combined with psychotherapy. The psychotherapy can be typically cognitive behavioral therapy, individual or group. The goal is to help the client identify and correct distorted, negative, and catastrophic thinking, thus relieving symptoms. Cognitive behavioral therapy attempts to modify maladaptive behavior through homework assignments, structured schedules, other techniques. Family therapy is used. Somatic therapies, if needed, like ECT, phototherapy. In ECT, that electroconvulsive therapy, for those whose depression fails to respond to meds and other modalities, is thought to modify the neurochemical environment. Phototherapy, especially for those with SAD, they are exposed to special lights. It's thought to increase melatonin, and in order, you have to have melatonin to make serotonin and vice versa. Treatment is most successful for those in whom symptoms are completely eradicated as opposed to just controlled. And so again, we'll be talking more about some of these other techniques, particularly stress management techniques, assertive techniques, ways to increase self-esteem, and certainly meds. Your meds include your SSRIs, your SNRIs, your SARIs, TCAs, MAOIs, and atypical antidepressants. All of the meds, all of the classifications in which you're going to do a classification sheet to have a better understanding after you do the ATI module, Pharmacology Made Easy, Neuro Part 2, to help you with your understanding of these pharmaceutical agents. Aaron Beck, you remember I talked about him before. He was an early psychotherapist. He noticed that clients with depression tended to have a certain combination of negative attitudes, which he called the cognitive triad of depression. Clients with depression have a tendency to draw global conclusions from a single isolated event while ignoring incoming data that could provide contrary evidence. They then generalize this thinking to other areas in their life. Clients with depression see the future as continued trouble, hardship, deprivation, and frustration. They see the world as demanding, hostile, and full of obstacles, and they see themselves as deficient and inadequate. These personal deficits result in unpleasant experiences. Cognitive therapy interventions include working actively with clients to change these faulty thought patterns. Here's a little question. Is the following statement true or false? The use of psychotherapy or medications alone is more effective than a combination of the two approaches when treating depressive disorders. What do you guys think? It's actually false. A combination of meds and psychotherapy is more effective than either approach alone. Cognitive behavioral therapy approaches include individual or group therapy or both. The goal is to help the client identify and correct distorted, negative, and catastrophic thinking, thus relieving their symptoms. Now, if you want to get your understanding straight, comparing sympathetic and parasympathetic nervous system will really set the stage for you to have a better understanding or a deeper understanding of the way neurochemicals work, if you will. So this little YouTube video will help you review sympathetic or the adrenergic and parasympathetic or the cholinergic nervous systems. This will set the stage for better understanding of neurotransmitters and how meds work, especially when you think about anticholinergic or the anti-parasympathetic side effects. So I would strongly encourage you to go to this little link and watch this video. It's very, very helpful. And again, talked about these before, but this is a graphic review of the main neurotransmitters and what they do. And you can see that norepinephrine, concentration, certainty, determination, recall, memory, serotonin, satisfaction, relaxation, pleasure, learning, memory. You can see that it shows on the other, kind of on the other side, across from like relaxation, pleasure, learning, memory, for instance, gives you insomnia, anxiety, and disability. So when serotonin is not in balance or low, these are the outcomes. Norepinephrine, again, more outcomes there. And dopamine. So all of these together give you a balanced mood when they're all working well. We'll talk more about these in class. So we're looking at psychopharmacology antidepressants. Because each client is unique, often the med choice is by trial and error based on side effect profile and the client's symptoms. All these meds act on the level of the neuron. They either change the receptor itself, they alter the metabolism or breakdown of the neurochemical, or block its reuptake. The drugs of choice for depressive disorders, including the depressive phase of BPD, these are our antidepressants. They're used for moderate to severe depression with impairment in social or occupational functioning or suicidal ideation. As I said before, it's kind of by trial and error. One med might work really good for somebody and then not very well for someone else. So one size does not fit all. All act at the level of the neuron. Decrease in symptoms can take anywhere from 2 to 6 weeks. The minimum time frame for the trial is usually 4 to 6 weeks before assuming that the drug has failed. The client must be on the drug long enough to ensure appropriate dose titration and achievement of target dose range. Long-term therapy is usually indicated, but there are some deterrents to maintaining treatment, if you will. And one of the deterrents is the length of time for the symptoms to subside and the potential lethality, particularly when you look at the classification of the TCAs, or the tricyclic antidepressants. They have a risk of overdose because they have a very narrow therapeutic index, meaning that adjusting the dose is tricky. You can get too much very easily and get them into toxicity or overdose. So typically when they prescribe a TCA, they will prescribe it for a very limited amount. And then that person has to refill it pretty often to keep up with the therapy. So that can be a deterrent. Antidepressants can also precipitate mania in clients with bipolar disorder or activate latent psychosis in susceptible clients. You should teach people to never discontinue abruptly. They have to discontinue by slow taper because there are severe rebound symptoms with rapid return of original depression if a person comes off these drugs abruptly. So the SSRIs are the first-line drugs for depression, and these have fewer side effects than other antidepressants. Typical side effects like GI, nausea, vomiting, diarrhea. Central nervous system effects, headache, nervousness, anxiety, lightheadedness, and sexual side effects include decreased libido. And I can tell you from observation and anecdotal evidence that it is the sexual side effect of the decreased libido that makes people come off these SSRIs more often than anything. The SSRIs have few to no anticholinergic or cardiotoxic effects. There is a possible lethal reaction, though, serotonin syndrome, especially if combined with other serotonin-type agents, gives you hyperactivity of serotonin in the CNS. That 5-HT is the symbol for serotonin. The newer generation of these drugs are the SNRIs. And I guess I should tell you that the SSRIs are selective serotonin reuptake inhibitors. So they're trying to keep more serotonin in the synapse, if you will. The next one, SNRIs, selective norepinephrine reuptake inhibitors, if I could talk right. And the last one, SARIs, are the serotonin antagonist and reuptake inhibitors. So again, you're trying to keep more of the chemical in the synapse so the person doesn't become symptomatic when those chemicals are deficient. Here's a little, these nursing education consultants, it's kind of a little comic type thing. If you've ever looked at like Nursing Made Easy and stuff, they use a lot of these just to kind of, summarize, give you a quick reminder. And for some people, these kind of things work really good. I've included them in. If they'll help you learn more about the meds, that's great. Serotonin syndrome is an adverse drug reaction, and some predictors for serotonin syndrome, other antidepressants, herbals, like particularly St. John's wort, over-the-counter cold meds, illicit drugs, amphetamines, meperidine or Demerol, other pain meds, anti-infectives, and antiretrovirals. So to recognize serotonin syndrome, you will see changes in mental status, hypomania or agitation, hallucinations, delirium, coma, seizures, motor function, ataxia, hyperactivity, rigidity, hyperreflexia, tremors, and in autonomic function, tachycardia, hypertension, fever, which is a really bad sign, emotional lability, and diaphoresis. The next category of drugs are your tricyclics or your TCAs, tricyclic antidepressants. These block the reuptake of norepinephrine and serotonin and decreased problems. Therefore, they decrease problems with, and that should be mood, MOOD, and energy. I don't know how that typo got by, but sometimes you're typing fast and furious and they just go right by you. It's not to be used in clients at risk for suicide because remember I told you it has a narrow therapeutic index, increased potential for toxicity, therefore lethality. It has anticholinergic effects, and the cardiotoxic effects are pretty crucial. You use caution in patients hypersensitive to any of the tricyclic drugs, those taking MAOIs and those who have had a recent heart attack. They're also contraindicated in lactating women, used with caution in clients with cardiovascular disorders. Closed angle glaucoma is from the anticholinergic effects. BPH, certainly constipation, seizure disorders, impaired hepatic or renal function. So those are just some cautions there. Here's another one of these little slides with the tricyclic antidepressants kind of summed up. So hopefully that'll give you a few clues on your meds. Monoamine oxidase inhibitors, or your MAOIs, work differently than your SSRIs and TCAs. They block the activity of MAO, MAO is an enzyme that breaks down catecholamines, especially norepinephrine, in the neuron. They are used infrequently since the development of SSRIs and related drugs, but they're used to treat atypical depression in non-responders to other agents. They increase levels of something called tyramine. If the client overdoses, takes other meds that interact with MAOIs, or eats foods with tyramine, norepinephrine accumulates and it brings about a hypertensive crisis. This is a critical condition that requires immediate medical intervention. So there's your little slide on your MAO, your MAOIs. There's another slide. So between the two slides, what I like about this second slide is it summarizes, if you will, or gives you a good picture of what foods to avoid, because these are the foods that are high in tyramine. Aged cheeses, wine, and pickled foods, they are all bad for a person taking an MAOI. Atypical antidepressants are considered safer than the TCAs or MAOIs. These are considered the second-line antidepressants. Bupropion or Wellbutrin. This is a weak blocker of the serotonin reuptake, a potent blocker of the norepinephrine reuptake, partially inhibits reuptake of dopamine. It's antagonist to the nicotine acetylcholine receptor. So if you've ever heard of Wellbutrin, or bupropion used for people that are trying to quit smoking, it is a smoking cessation agent. It's not appropriate for clients, though, with seizure disorders. It does not inhibit MAO or cause the sexual side effects that you see with many of the SSRIs. It does lower the seizure threshold, so you have to be real careful in someone with a history of seizures. And here's your bupropion slide, or getting well with Wellbutrin. Atypicals continued, mirtazapine or Remeron, dual action of increase noradrenergic and serotonergic transmission. It has the ability to block two specific serotonin receptors, and it causes fewer anticholinergic, cardiovascular, and cognitive disturbances than your TCAs. One of the main ways you'll see Remeron in use is they use it to for a person who's having trouble with their appetite, like a cancer patient. They'll often put them on this to increase their appetite. It works pretty well for that. I really don't see it used an awful lot for depression, but I have seen them use it in elders with depression, particularly those elders that have kind of quit eating, and they try that to get them to eat a little bit better. There's selegiline. Comes as a selegiline transdermal patch, approved for major depression. It blocks MAO enzyme in the brain and the gut, but the same dietary restrictions apply. You have to watch those foods high in tyramine. Somatic therapies include phototherapy, used for SAD. Exposure to bright lights 2 hours per day in the morning to mimic the natural circadian rhythm. It's thought to increase melatonin. And again, melatonin helps make serotonin, and you need enough serotonin to make melatonin, so it kind of goes back and forth. An ophthalmic exam is recommended prior to treatment, but there is less danger than there used to be of ophthalmic damage with these lights, with the light therapy. They've become much safer to use. Some mild side effects include headache, eye strain, visual disturbances, nausea, and sweating. There's a picture. Electroconvulsive therapy, again, we talked about that in the conceptual basis of treatment. Used for clients whose depression has failed to respond to other meds and modalities. Small doses of electricity applied to the brain produces seizure activity. thought to modify the neurochemical environment. Main side effect is memory impairment. Can be mild forgetfulness to severe memory impairment, which may persist for weeks or months. Here's another picture, again done in the OR. Transcranial magnetic stimulation is approved for non-responders to meds and modalities. The magnet is placed in contact to client's head to stimulate superficial cortical neurons. Studies are not conclusive here. They're really not seeing an awful lot of really good results here. But anyway, that's TMS. Vagal nerve stimulation, which we talked about a little while in the last podcast, used for non-responders to meds, other modalities. It's an implanted device stimulating the vagal nerve, which feeds back to the brain's limbic system. Studies show promise with relief of depression lasting up to 24 months. And here's a picture for you. I didn't include a picture in that the conceptual basis of treatment slides, but here's a picture. There are other therapies. SAMI, used to treat mild to moderate depression, regulates action of serotonin and dopamine. It takes effect in about 10 days, is found naturally in every human body cell. And they did, the National Institutes of Mental Health did a very limited study. Actually, they only had 73 participants, but they showed a significant response with SAMI over a placebo for the treatment of depression. Other therapies, yoga, relaxation techniques, acupuncture, magnet therapies, exercise to augment psychotherapy and or psychopharmacology. Nursing assessment. Oh, here's a question. Is the following statement true or false? The use of psychotherapy or medications alone is more effective than a combination of the two approaches when treating depressive disorders. And you know that it is more effective with a combo of psychotherapy and medications together. So, nursing assessment, mental status exam. Assess for signs and symptoms. Look at the person's grooming and appearance, facial expression, posture. Is affect congruent with mood? Has there been a change in the energy level? Psychomotor agitation or inertia and withdrawal? Has there been changes in thought content? Is it confusion, difficulty concentrating, thought blocking? Is the client preoccupied with thoughts of suicide, poverty of ideas, negative view? Is the client experiencing thoughts of loss and abandonment, worthlessness, guilt, hopelessness? Is depressive illness accompanied by psychosis, hallucinations, persecution-style delusions, disturbed judgment, limited insight? Has a person had interference with their ADLs, their occupation, their work? There are many. Here's another little pictorial for you. There are many scales and screening tools for depression. One's the Beck Depression Inventory. It's a 5-minute, 21-item scale that assesses the intensity of depression in people 13 to 80 years of age. There's also the Hamilton Rating Scale for depression and the Zung Self-Rating Scale, Self-Rating Depression Scale. We'll do one of these in class. Safety is a priority assessment for the client with depression. Suicide is a primary concern. Violence toward others is also a concern. Warning signs of potential violence include ideas about or intent to harm others, history of violent behavior, severe agitation or hostility, active psychosis with command hallucinations. Factors that increase a client's risk for suicide: expression of current thoughts, plans about suicide, active mental illness, substance abuse, past history of suicidal attempts or behaviors, formulation of a plan, availability of means for completing suicide, and disruption of important personal relationships. Failure at personal endeavors is also another risk factor. So is the following statement true or false? Forthright questioning about suicidal thoughts or plans increases the risk of suicide. That's actually false. Direct, non-judgmental questioning is most effective. Clients often report feeling relieved that someone has asked them in detail about suicidal thoughts. Nursing assessment to continue looking at physiologic stability, neurovegetative signs, self-care deficits, increase or decrease in appetite, constipation, disturbed sleep patterns, typically again that early awakening and then fatigue and exhaustion the next day, decreased energy, decreased libido. Nurses will assess for weight gain or loss, appetite changes, bowel pattern changes, sleep disturbances, energy level, and libido. Some nursing diagnoses for clients with mood disorders: risk for suicide, risk for violence toward others, ineffective health maintenance, impaired social interaction, disturbed thought processes, ineffective therapeutic regimen management. There are others. Often these patients have physiologic instability. They may avoid eating. They may have difficulty sleeping. They may have an inability to do self-care. They may have vegetative signs that produce problems with appetite, nutrition, sleep, elimination, libido, sexuality. How about ineffective health maintenance? I mean, there's all kinds of nursing diagnoses that fit clients with this disorder. So some outcomes here: when we do write a nursing care plan, we choose one of these. The most important priority is maintaining the client's safety as well as safety for others. Possible outcomes: suicide self-restraint. The client will remain safe throughout hospitalization and while receiving care in the outpatient setting without harming self. Aggression self-control. The client will remain safe throughout the hospitalization and while receiving care in the outpatient setting without harming others. Self-care status. The client will have adequate food and fluid intake, will maintain balanced rest, sleep, and activity, and will maintain personal care. Social interaction skills. The client will engage in appropriate social behavior. Distorted thought self-control. The client will demonstrate logical, reality-based thought processes and will to live. The client will consistently maintain the medication regimen, including taking meds as ordered and follow-up care, thus the will to live. Nursing interventions for clients with mood disorders. Nurses use many types of interventions to assist recovering clients and families. You can see on the left-hand column: promote safety precautions, provide for physical needs, employ active listening, promote expression of feelings, utilize cognitive restructuring techniques, enhance positive coping strategies, instill hope, manage mood, enhance self-esteem, provide for socialization needs, provide spiritual support, enhance adherence to treatment regimen. So there's many, many interventions. And we nurses use many ways to employ these nursing interventions. Now, a lot of these patients are going to want to be by themselves. And so a lot of times what we have to do is, meaningful socialization. We want them to participate in the milieu, the activities, the hobbies, the group discussions. And we want to prevent isolation if appropriate. However, if the client is very anxious, then it's best to provide a low stimulation environment, perhaps the client's room, but make sure you keep them in sight. Here's a nice little concept map, if you will, for depression. And so I included that in your slides. I thought it would be a nice slide for you to review. Kind of summarizes everything we talked about. So how do we evaluate our plan of care for the effectiveness of our interventions? Well, here's some of our goals. The client reports fewer or no suicidal thoughts. The client refrains from self-harm or aggression. The client independently manages self-care. The client participates appropriately in milieu activities. The client expresses a positive sense of self-worth. The client adheres to the therapeutic regime. And that is the end of the podcast for depressive disorders. We'll do a lot more activities in class to just kind of hone in on a lot of this and make this come alive for you. So that's the end of the podcast.